Okay, so we're gonna try and take a thoughtful, reflective approach on stuff that we do all the time in medicine, and hopefully extract from that not only to do it better in healthcare, but also in just spilling over into our everyday lives. And you've probably heard me say a number of times, and one of the real epiphanies that I had was that evidence-based medicine, the core principles and even core tools or tools at their core apply across life. And so what we're going to talk about today is a test. And I want to make this interactive, but also try and keep it as short as possible. So if I seem a little bit hypomanic here, you'll understand that I'm trying to really do it for your benefit. What would you say a medical test is? Or maybe even just a test. What is a test for anything? And then we'll define it more narrowly as a medical test. To see if something's functioning. Would you say it would be fair that a test is something that gives us information about whatever it is that we're interested in? So I'm going to say anything that provides information about, and then we'll put in a blank. So in the case of medicine, it's about the patient, right? And so we can, for a medical test, so we're thinking about testing here. And when we use tests, we have to think about questions like, what test do we use? What constitutes a good test? What is a useless test? Things like that. And in order to do that, we have to look at why would we use further testing? And so we can break that down into pre and post. All right, and when I say pre and post, I'm giving this with reference to the test itself, the test in question. So the pre has to do with the pre-test probability. Have you heard that term before? Okay, some of you have. So pre-test probability. Probability of what immediately comes to mind. And then the post-test probability. And in the case of real life, I'm going to use an example of the carpet smells. Okay, that is our symptom or our finding is the carpet stinking. So let me see if I have a nicely colored. It's kind of gaudy, but whatever. So carpet stinks. And in the realm of the healthcare, we're going to say wheezing. So what does approaching wheezing have to do with approaching why the carpet stinks? Well, that's what we're going to find out. So if the carpet stinks, you're walking through the house and it's like, oh, that smells weird. Automatically, and this is what I'm trying to get across, is that so much of what we do in medicine, actually, if we reflect, is the same thing that we do in our lives, and it's automatic, and we were wired this way. It just helps to be aware of it. Well, we're going to develop a list of possibilities of why the carpet could stink. So I'm going to suggest to you that we could have one, dog pee. Okay. Number two, maybe water leakage or water seepage from somewhere, who knows. 3 would be maybe spilled food. And, or drink. And number 4, global warming. So, so what do we call this list? If there's a technical term, I mean, I've called them possibilities, hypotheses. We could call them that. In medicine, there's a technical term, and you've all heard it because we throw it around all the time. So we're trying to make a diagnosis of carpet stinking. And this list of possible diagnoses, which is always got to be subject to change, pun intended, but it's a fluid thing. I'll resist the urge to make more bad jokes. We call this a differential diagnosis, right? Because you're trying to break down, it could be this, it could be that, these different things. So with, we'll do the same thing with wheezing. So how do we know? So we go into this and we say, well, I'm not sure. Just based on smelling it, I'm uncertain. And in general, I think a good way to think about pre and post-test probabilities, yes, we can come up with numbers, but it's really kind of a gut thing. Is it low? And within low, you could have like very low, or you could have intermediate, or you could have high. So when would the test low, intermediate, and high, and the same thing for down here? When do you suppose an additional test beyond the information that you already have to figure out which one of this list is there? If you have a really low probability pre-test that something is there, do you think you need another test to determine that? Most likely? No. How about really high? Well, no, if your pre-test probability is really high, you're not necessarily going to get more testing because you're already so confident. If I have somebody who has had a fall and they are in agony and they hurt right here, and I look at them and their leg is foreshortened and externally rotated, I'm not going to, my pre-test probability that they have fractured the femoral neck is very high. And so further testing there is not going to be, well, gee, did they break their femur or not? But there it would be more, characterizing the fracture, where did it break, and so forth. So testing is, in general, is going to be the most helpful when we have an intermediate probability. Now, that's a wide span, and where our comfort levels lie is going to depend. Sometimes it's not that big of a deal if we miss something. If I don't determine the exact cause of the dog pee, nobody's going to die. But if we've got somebody with low blood pressure and they look like they're going to go downhill quickly, I want to be pretty sure what I am or I'm not dealing with. So all of this is kind of fluid, it's context dependent. So how do you then determine which test is a good test? Is there any, can you just look at any given test and say, aha, this will always be the right test?
No.
No. So the right test is context dependent. What do we do in our day-to-day medical thing or in day-to-day lives that would constitute tests? If a test is anything that provides info about, in this case, the carpet or the carpet smelling or a patient, then a test would be anything that would provide us with information, wouldn't it? So everything is a test. And I wish this would have been taught to me. As you know, much of my teaching approach is based upon my intense frustrations over many years of trying to scrape and struggle to just please, somebody give me some simple tools. And now after all these years, I'm hoping that I can take some people and make their lives easier for them by these kinds of observations. So, so it could be any additional information, which could be what? It could be a question that we ask, it could be our eyesight, it could be a comment from a family member, a comment from a coworker, and that could make all the difference in the world. And I mean, I'm sure you've experienced this. A family member says, oh, X, and like it takes us down a much different path that is much better for the patient. So, what tests might I do if I'm going to determine the cause of the carpet stinking? If I think that, first of all, I have this list of 4 things. What is your pre-test probability that it's dog pee, water seepage, spilled food or drink, or global warming? Would this be high, low, or intermediate? Ah, excellent. So I need that information. So if it's my house, we know that we have dogs. But if you're talking to just, if you ran a business of carpet cleaning, you can't assume that it's dog pee, because if they're allergic to dogs and you know that they wouldn't have them, then that goes down, way down on the list. So do they have a dog? So that's going to be the first test. Let's say water seepage, right? So likely, not likely, intermediate probability, somewhere in between, just kind of on the face of it. I mean, I would probably call it intermediate. And it's going to depend on your context. So what kind of tests would you have? Well, do you have where do you live? Do you have a leaky roof? Are you in high desert? Probably not as likely that it's going to be right near a bathroom. Excellent. So you see, all those things are tests, but I was never taught to think about questions this way. So this has huge implications, and it makes, I think, our mundane activities that we do in medicine a lot more interesting. Because you go to the bedside and say, oh, this exam is a good test, it's a bad test. I was taught to just do all these things, and it's important that we learn the techniques, but how to apply them is the key, because a lot of it's worthless, depending on context. Also, depending upon the quality of the test, and we'll get into that briefly. So, just going through this, you've kind of fleshed out here that the probability of these is going to be dependent upon certain factors. Do you have dogs? Are you in a wet climate, a dry climate? Where's the carpet located, and so forth? How sloppy is the physician who happens to live in the home? Oh, sorry. And then global warming. Anybody voting for high probability for that? Yeah, I mean, it's ridiculous, but I throw it out here because it helps to illustrate, if your electricity goes out, is it a circuit breaker? Is it a storm? Did somebody have an accident into the power pole down the road somewhere? Did we have an EMP, right? I mean, that EMP is theoretically possible, but not very likely. Okay, and then we'll go through it. And so the testing I might do in addition is I'll just go through the room and look and say, oh, there's this wet circle on the floor. Well, now my probability that really doesn't necessarily distinguish between nose, but then I use my nose and go down and it smells like pee, and so our Australian Shepherd must have peed on the carpet. So applying this to wheezing then, somebody says, well, I've got wheezes. They get called, and as you know, my wife is a respiratory therapist, and we have these kinds of discussions because there's this sort of reflexive thinking that can be there. Well, if they're wheezing, or if I hear a wheezing noise, it must be something that I throw albuterol at. And when we get into the medical realm, that's where it becomes much more serious, because now we're talking about treatment implications. And so are we going to give them a medication that could occasionally cause people to feel worse, jittery, or occasionally throw them into AFib or something if they already have it, or speed their rate up, things like that. So it could be unpleasant to even potentially, occasionally somewhat dangerous or harmful to the patient, or just a waste of money and time. And so when you hear the term wheezing, well, what would be a test that somebody, rather than just say wheezing equals albuterol in this case, well, are all wheezes the same, or is there like a list of possibilities for wheezing noises, right? So this is sort of a genus, if you will, and we have species of, we could have, I'm going to call this upper airways, right? So throat down into here. It could be bronchospastic, so-called cardiac wheeze, right? Well, of this short list, well, that's a terrible heart. Of these three, how many of them are actually responsive to albuterol?
One.
Just one, the bronchospastic. How often do we actually hear bronchospastic as opposed to particularly when I'm putting in a broad category of upper airways? We hear this all the time. So what could be a test that we would do to distinguish very simply between this and this?
Auscultation.
Sorry?
Just listening.
Yeah, you mean like with the stethoscope?
Yeah.
Yeah, auscultation, exactly. And so this is where we look into the quality of a test. So we need to know which one let's say the quality of the test chosen. So for example, we could talk about an x-ray with poor penetration, right? They don't have enough intensity of x-rays on it. Well, now it may be the right test, but the quality of it has gone down. Or if it's over penetrated, or the patient is not positioned well. So there's the test. We could put the performance of the test. History questions are this way. You know, I remember as a med student, I could spend 45 minutes with a patient asking questions, and the attending comes in, and in 2 minutes they've got different answers than I do, and I'm just like, why? You know. So upper airways, anything that is from the throat down to the level of the bronchioles could be broadly in this, I'm just going to throw it in this category. It's junk in the airways that's making a wheezing noise. So we listen, and where we listen, the timing, the quality, you know, as we get more trained, which means that we can take our tests and improve their quality even as we do it, which is another benefit of just kind of reflecting on this process. And what else could you do to distinguish between these two? Because it's not always, it can be difficult. The upper airways noise can be transmitted downward. A lot of times if you go upward with the stethoscope, if it's getting louder and louder as you get closer to the throat or the bigger airways, then that takes your post-test probability up. And I have this happen actually pretty commonly, and say, well, no, I think this is primarily or exclusively upper airways. But there's something else we can do that will enhance the quality of the test, and therefore its post-test probability usefulness, and that is just have them cough, right? Because if they clear secretions and now you don't hear the noise, or they take a bunch of deep breaths and things clear, and so now the wheezing noise has gotten better. So this is really a kind of a microscopic walk through this, but if we start thinking about this in our daily lives, and as we walk around the hospital, again, I just think we get much better in terms of our thinking. And the whole point of the test is to take the pre-test probability and change it, right? If the pre-test probability is intermediate, we want the post-test probability, whatever test we choose, should change it to either really high or really low. Otherwise, it's a useless test, right? If someone isn't feeling well and I ask them, what's your astrology sign? I mean, that could be a test, but it doesn't change my post-test probability of why they feel that way. But if I choose a test because of the way they look and I say, did you just suffer a family tragedy? That might be the right test, but if their leg is foreshortened and externally rotated, it's probably not going to be a very good test. So the right test is the one that hopefully eliminates the need for further testing and determining whether it's dog pee or global warming or whatever, or upper airways versus cardiogenic or versus bronchospastic. So hopefully that's a helpful walkthrough on this, kind of a set of tools that we can bring to bear. And if my power was out, if my ice cubes were melted, if my shoe is squeaking from the orthotic, as it often does. I still haven't really found a good test for that to distinguish. Or if we're looking at wheezing or chest pain or, and this is why we have these calculators, like somebody's got chest pain, and if your list includes pulmonary embolism, well, what tests will determine whether that is low or high? Well, they've got a leg that's 3 times the size on the one side that it is on the other. Well, that takes your probability way up, right? Versus they were trying to clean the dog pee out of the carpet, and they were pushing really vigorously, and they've got muscular pain, and you push on it. So, anyway, any questions, comments? I hope that was helpful.
Yeah, thank you.
You're welcome.